Maybe community health clinic work would suit someone with your authority issues. That is what Dr. Whitfield said 17 minutes before Captain James Morrison arrived with shrapnel tearing through his heart. Margaret Walsh moves through Seattle General's night shift in Philadelphia with the mechanical precision of someone who has forgotten how to be visible. She adjusts for drips without looking, the needle sliding beneath translucent skin with the confidence of muscle memory that spans 2 decades. Her chart notes appear in identical block letters, each vital sign recorded at exactly 0400 hours, 0430 hours, 0500 hours, the kind of obsessive documentation that leaves no room for interpretation or error. The fluorescent lights hum against antiseptic-scented air thick enough to taste, a sterile white noise that most nurses tune out after a few years. Margaret has heard it so many times it sounds like machinery inside her own chest. The night shift at Seattle General runs like a skeleton cruise vigil, 12 beds, for nurses, one overworked resident who disappears into the call room at 2 a.m. and doesn't emerge until dawn breaks through the windows like an accusation. The cardiac ward on the 3rd floor is hers. She knows which monitors wheeze, which for pumps stutter on the downbeat, which elderly patients wake at 0300 hours asking for water they won't drink. She knows the hospital the way a soldier knows a forward operating base, every exit, every supply closet, every camera angle. Her orthopedic clogs squeak against the linoleum, which is yellowing at the edges near the nurse's station, and she moves with the economical gait of someone rationing energy across 12 consecutive hours. She keeps a tarnished challenge coin in her left scrub pocket, beneath the pocket watch she uses to time cardiac compressions. The coin is no longer silver, it has oxidized to the color of old bruises, purple and gray, and the eagle stamped into its surface has worn smooth from 43 years of thumbs running across its face. She finds it during her 0200 break, sitting alone in the medication supply room, door locked, and she presses the metal against her palm until it warms to skin temperature. The coin has become a prayer she cannot say aloud. She runs her thumb over the worn surface, over the indentation where words used to read, before they were filed away along with her social security number and her previous name and the address of a brownstone in Georgetown that no longer appears in any database. The supply room smells like bleach and rubber tubing, and she stands there for exactly 4 minutes before sliding the coin back into her pocket and returning to her floor. A surgical scar runs from her right wrist to elbow, rope-thick and puckered, the color of bone. She got it in 2009 when a building collapsed in San Juan Valley, Helmand Province, during an extraction that was never officially documented and never will be. The scar has become part of her uniform now, visible when she reaches for high shelves during med pass, visible when she draws blood from a patient's antecubital fossa, visible enough that junior residents sometimes ask if she was in an accident. She tells them the truth without lying, a long time ago. She does not tell them that she was a Master Chief Petty Officer when it happened. She does not tell them that her hands have held more dying soldiers than most surgeons see in a lifetime. She does not tell them that she was given a new social security number and orders to disappear, and that disappearing has meant working night shifts in a 3rd-floor cardiac ward in a city where no one would ever think to look for her. Dr. Whitfield appears during the 0315 med pass, his Oxford shoes clicking a rhythm against the linoleum that makes junior nurses straighten their spines and check their hair. He is tall in the way men are when they have never had to crouch in a bunker, and his silver hair is styled in a way that costs more than Margaret's car payment. His white coat fits his shoulders without a wrinkle, and his stethoscope is a Littmann cardiology for that probably cost $400. He moves through the ward with the territorial efficiency of a man who owns the space, checking medication carts without asking permission, reviewing charts with his pen poised like a weapon. Margaret continues her work. She does not look up. She does not change her pace. She has learned that invisibility is a form of defense. The less remarkable you are, the less memorable you become. But today Whitfield stops at her medication cart. He lingers. He breathes through his nose like a man smelling something spoiled, and when he speaks, his voice carries the condescension of someone explaining a simple concept to a child who refuses to understand. Your bedside manner has become problematic, Margaret. She continues measuring dextrose into a syringe. Her hand does not shake. Her voice, when she answers, is pitched low and even. The patients are stable, Dr. Whitfield. That's not the point. He moves beside her, close enough that she can smell his cologne, something French and expensive that costs more than her shift pay. The point is autonomy. You perform interventions without consultation. You adjust treatment plans without authorization. You move through this ward as though you've forgotten the hierarchy that keeps this place functioning. She does not respond. Responding is arguing. Arguing is rebellion. Rebellion is visibility. Whitfield sets his pen on her cart with a click that sounds like a trigger being pulled. I'm going to be direct. Community health clinic work might better suit someone with your authority issues. Less complex cases. More straightforward protocols. You could work at your own pace without the burden of institutional oversight. There is a moment, exactly 3 seconds, where the fluorescent lights seem to brighten, and Margaret feels something shift in her chest like a tectonic plate finding its fault line. He is suggesting that she resign. He is telling her she does not belong in his hospital. He is constructing the first domino that will fall in the direction of her disappearance. She does not flinch. She does not speak. She finishes measuring the dextrose and marks the medication on her chart with meticulous handwriting, every letter perfectly formed, and when she looks at him, her eyes are the color of a winter sky over the Atlantic, flat, unremarkable, utterly empty of the rage that lives in her bones. I appreciate the feedback, Dr. Whitfield. He nods, satisfied that his message has landed, and walks away, his footsteps echoing down the corridor. When he is gone, Margaret reaches into her pocket and touches the challenge coin. The metal is cool now, and heavy. She stands at the medication cart for 7 seconds, just breathing, just feeling the weight in her hand, and then she slides the coin back into her pocket and returns to her work. Her patients wake at 0400 hours. An 87-year-old named Mrs. Chen wants water. A 53-year-old with unstable angina named Mr. Rodriguez cannot sleep. A 71-year-old named Mr. Patterson keeps trying to pull out his central line because he is confused, because his oxygen saturation dropped to 88% during the night, because the body does not distinguish between age and fear. Margaret sits with each of them for exactly 6 minutes, the amount of time it takes to deliver care that does not require a protocol or institutional oversight, the time it takes to hold a hand, to adjust a pillow, to whisper that she is here and they are safe. She does this the way she used to do it in a forward operating base at 2 a.m. when soldiers woke screaming from morphine dreams. The technique is identical. The compassion is identical. The invisibility is deliberate. But that is not the worst part. At 0527 hours, before the day's shift arrives, before the sun pulls itself over the Philadelphia skyline and turns the night sky the color of old copper, the emergency room intercom crackles, incoming medevac. Military casualty. ETA for minutes. Trauma Bay 1. The announcement repeats twice, and Margaret is already moving. Not toward Trauma Bay 1, that is not her assignment, not her floor, not her jurisdiction. But the moment she hears medevac and military, something inside her wakes up, and she can feel the adrenaline surge like muscle memory, ancient and immediate. For minutes later, a UH-60M Black Hawk lands on the roof of Seattle General with the rotor wash loud enough to shake the windows on the 3rd floor. Margaret pretends not to hear it. She continues her charting, her hand steady, her breathing controlled. She has trained herself not to respond to that sound. She has trained herself not to run toward a helicopter like it is calling her home. The patient arrives at 0531 hours. Captain James Morrison. 3rd Battalion, Special Forces Command. Shrapnel wounds across the left chest cavity with cardiac tamponade, the pericardial sac filling with blood until his heart cannot expand, cannot pump, cannot sustain the electricity that keeps a man alive. His blood pressure is 78/52. His oxygen saturation is 91%. His heart rate is 134, tachycardic and desperate. He is also conscious enough to open his eyes when they wheel him past the cardiac ward. Margaret is standing at the window of the medication supply room, just checking inventory, just doing her job, just invisible, when she sees him. Brown hair. Military bearing even when he is bleeding out. Eyes the color of storm gray concrete. She has seen those eyes before. She has seen them in emails her son sent from Forward Operating Base Shank in 2014, quoted in letters, referenced in the photographs that arrived after the incident that buried him so deep they had to give her a new social security number just to survive the silence. Captain Morrison is being rushed toward Trauma Bay 1, toward surgery, toward a surgeon who will have to crack his ribs and reach directly into his chest with hands that are steady and learned and completely unafraid of blood that came from a man who might have known her son. Dr. Whitfield is already moving, already on his phone, already coordinating the operative team. And Margaret stands alone in the medication supply room, her thumb pressed against the challenge coin in her pocket, and she waits to see where the rest of her life is going to go. The challenge coin was warm in her pocket when Whitfield's voice came over the intercom at 10:34 a.m., a summons to Conference Room B, his tone carrying the precision of a blade. Margaret didn't hesitate. She clocked out of the medication supply room, found Charge Nurse Patterson updating the board, and said simply, "Conference Room B. Do you need anything before I go?" Patterson's face tightened. She already knew. Everyone already knew. The conference room sat on the third floor of Seattle General, a space reserved for departmental meetings and grand rounds presentations where residents learned how things were done, how hierarchy worked, how a nurse who forgot her place could be repositioned like a chess piece. Margaret arrived at 10:41 a.m. to find 30 staff members already seated, residents in their short white coats, attending physicians in their long ones, 2 nurses from adjacent units, a pharmacist, a respiratory therapist, all waiting with the polite restlessness of people summoned to watch someone else's education. Whitfield stood at the front with a laptop connected to a projection screen, his suit pressed so sharply the creases could cut glass, his smile the kind that reaches the mouth but never travels higher. "Margaret," he said, gesturing toward a spot beside the projection screen. "Perfect timing. Stand here, please." Not a question. Not a request. She moved to the position he'd indicated, hands clasped behind her back, and waited. Whitfield clicked the first slide. It read, "Nursing Autonomy, Blessing All Liability," in Arial bold, oversized enough that it dominated the entire white wall behind them. The fluorescent lights hummed their institutional song, that constant electric pressure that never stopped once you started noticing it. "What I want to talk about today," Whitfield began, his voice carrying the confidence of a man who had never been interrupted in his own department, "is what happens when nursing staff make decisions without appropriate physician oversight. Let me introduce you to what I call the Lone Ranger approach." He gestured toward Margaret without using her name, and scattered nervous laughter rippled through the residence, the kind of laughter that comes when the room's hierarchy is being clarified in real time. Margaret's jaw muscles flexed once. Her eyes fixed on the back wall at a point approximately 3 inches above the clock. He clicked to the next slide, a timeline of her charting from the previous week. 3 entries. 3 decisions. He enlarged each one, projected them across the screen like evidence in a trial, and began to dissect them with the precision of a man who had spent hours preparing this moment. "Look at this notation," he said, pointing to her entry from Tuesday at 14:22 hours. "Patient experiencing respiratory distress. Nurse Walsh initiates positioning change and oxygen adjustment without waiting for physician evaluation." The resident who caught this excellent work, Dr. Chen, noted that the patient was already on appropriate oxygen saturation. But our nurse here didn't wait to confirm that. She acted. She assumed. She positioned herself as the decision-maker. He turned to look at Margaret directly. "What was your thinking there, Walsh?" His voice was conversational now, almost curious, the tone a predator uses when it's already certain of the kill. "Patient was compensating," Margaret said. Her voice came out flat as a dial tone, each word precisely measured. "Tachypneic. Positioning change addresses anxiety. Oxygen adjustment was within standing protocol." She said nothing more. She didn't defend. She didn't explain beyond what was asked. This was the mistake Whitfield wanted, for her to speak, to justify, to prove that she thought she had the right to explain herself to him. "Ah," Whitfield said, turning back to the screen. "Standing protocol. But protocols exist within a framework of physician authority, don't they? Let me show you what happens when nurses operate on the assumption that they can implement standing protocols independently. He clicked through a series of slides, case studies from literature, outcome statistics, a photograph of a hospital where a nurse had exceeded her authority and someone had suffered. The room had gone very quiet. The residents were taking notes now, the younger ones actually writing down the phrases Whitfield used. Cowboys in scrubs. Dangerous independence. The kind of thinking that ends careers and ruins hospitals. The issue, Whitfield continued, is that Ms. Walsh seems to believe that her nursing training, valuable as it is, somehow qualifies her to make independent medical decisions. In this hospital, we maintain a clear hierarchy. Physicians diagnose. Nurses execute treatment plans. That boundary exists for patient safety, and more importantly, for institutional liability. He paused, letting that word hang in the air. Liability. The magic word that made administrators nervous. He knew his audience. He knew what would move them. One more incident like this, and we will need to have a serious conversation about scope of practice and whether our protocols are being followed as written. Margaret's hands, clasped behind her back, didn't tremble. Her breathing didn't change. She had been trained to absorb impact without showing the injury, the way a boxer learns to take a punch to the gut and keep moving. The room waited to see if she would react. She didn't. She stood there with the kind of stillness that comes from having already survived worse, and after 14 seconds of silence, Whitfield clicked to his final slide, a summary of recommended actions. Increased documentation requirements. Mandatory physician sign-off on all interventions. And a notation that said, any future autonomous decision-making will result in immediate disciplinary review and may warrant security escorts during shift transitions. This isn't personal, Whitfield said, turning to address the room rather than Margaret directly. This is about maintaining standards. This is about protecting all of you from the liability that comes with nurses who forget their role. He smiled at the residents. Remember this case study. This is what overreach looks like. This is what happens when someone confuses being helpful with being in charge. The meeting ended at 10:58 a.m. The residents filed out first, followed by the other attendings, until only Whitfield and Margaret remained in the conference room with the slide still projected on the wall behind them. Whitfield began packing his laptop with deliberate slowness, not looking at her. "You can go," he said finally. Margaret turned and walked toward the door at the exact same pace she had entered, her movements neither rushed nor defiant, just the ordinary gait of a nurse ending her shift. The second blow came 40 minutes later at 11:38 a.m. in the third-floor medication alcove, that small space between the elevators and the vending machines where staff went when they wanted to be alone but not conspicuously absent. Margaret had put $2 bills into the coffee machine and was waiting for it to dispense when Whitfield rounded the corner. He moved with the casual confidence of someone who had decided this conversation would happen, and it did. He leaned against the Coke machine button, blocking her path, his presence creating an invisible wall between her and the rest of the hallway. "You know what your problem is, Walsh." His voice was quieter now, which made it worse. Quieter meant he felt safe saying things the conference room would have required him to deny later. "You act like you're still somebody important. Like those decisions you made back when actually matter now. But they don't. What matters is that you work in my department, and in my department, we have a chain of command." He studied her face, searching for a reaction. Margaret inserted 3 more quarters into the slot and pressed the button for bottled water. The machine hummed and produced nothing. She pressed again. "Community health," Whitfield continued, "might be better for you. Less responsibility. Fewer consequences when you inevitably screw up. They're more forgiving down there. More accustomed to people operating outside their training." He stepped aside, finally, with a theatrical sigh as if he'd been standing there for hours instead of 2 minutes. Margaret collected her water bottle and walked past him without acknowledgement, though he called after her, "Think about it, Walsh. It might be your best option," and she kept walking. The third blow landed at shift change, 19:05 hours, when Patterson found her in the supply room and said quietly, "Whitfield told me to tell you that one more incident and you're getting a security escort to the parking lot. For your own safety," he said. The words had been delivered loudly enough in the hallway that 6 staff members heard them. That was the strategy. That was the point. Whitfield understood that humiliation required witnesses, that the real damage came not from the words themselves but from watching everyone else watch you receive them. Margaret had nodded at Patterson and returned to organizing the overnight supply cart, her hands moving with meticulous precision through for tubing and saline bags and alcohol swabs. She didn't feel fear. Fear was a luxury. Fear was something people felt when they still believed the system could be negotiated with, when they thought that patience and professionalism would eventually be recognized. She had passed that threshold years ago. The tarnished challenge coin in her scrub pocket, the one she'd received on her last deployment, the one bearing the insignia of her unit, felt heavier than it had that morning. She pressed her thumb against it once, just once, there in the supply room where no one could see her touch it, and then she clipped the full cart into place and headed toward the patient floors. Captain Morrison was conscious when she reached his bedside at 19:22 p.m., his eyes tracking her movement as she approached, as she checked the 4 lines, as she adjusted his oxygen tubing with the kind of careful attention that is either the mark of someone who cares or someone who has simply done it 10,000 times and muscle memory has turned it into poetry. The chest X-ray from that morning showed the shrapnel distribution clearly, fragments scattered across the superior mediastinum like shattered glass in a photograph. His chart noted stable vitals, pain controlled at 4 out of 10, responding well to conservative management. Whitfield's notes explicitly stated, "Do not escalate intervention. Surgical consultation unnecessary at this time." Margaret read the orders, then read them again, then looked at Morrison's face and saw something there that made her hands move faster through the vitals check. "How's the pain, Captain?" she asked, checking his blood pressure cuff, watching the numbers rise and fall on the monitor with the hypnotic rhythm of compression and release. "Manageable," Morrison said. His voice carried the flatness of someone medicated, but his eyes were sharp. He watched her work with the focus of a man who had learned to read situations through observation. "You're careful." Margaret didn't respond to that. She documented his vitals, noted the stable readings, and was turning to leave when Morrison's hand moved, just slightly, reaching toward her. "Wait," he said. "You know my name from somewhere." It wasn't a question. She could have lied. She could have said all officers' names look familiar after a while, that proximity creates the illusion of recognition. Instead she said, "Rest, Captain," with the kind of tone that closes conversations, and she walked out of his room at 19:52 p.m., her hand steady, her breathing controlled, while the challenge coin in her pocket seemed to pulse with her heartbeat like something alive and waiting. At 1:52 a.m., the central line monitor above Captain James Morrison's bed screamed. Margaret heard it from 20 feet away while restocking the crash cart, that particular pitch of alarm that meant pressure dropping, oxygen saturation plummeting, a body surrendering faster than medicine could compensate. She moved before the sound finished its 3rd pulse, for strides across the ICU floor, her shoes making no sound on the tile because she'd learned long ago that speed without noise meant not alarming the other patients, not drawing attention, not making a scene. Morrison's eyes had rolled back, the whites showing like a spooked horse. His lips were turning the color of slate. The central line pressure reading dropped from 95 to 88 to 72. 72. Below 50 was dead. She reached for the phone at his bedside, kept her voice level, kept it steady, the kind of steady that only came from having done this in places where screaming didn't save anyone. Code Blue, ICU 4. Captain James Morrison. Possible cardiac tamponade recurrence. The operator acknowledged. Margaret was already moving. The crash cart was 12 feet away. The thoracotomy tray sat inside it, the metal instruments arranged in the specific sequence required for an emergency chest crack, the kind of procedure you performed when the heart stopped and nobody else could restart it fast enough. She'd assembled this tray 417 times in her career. Not one of them had required asking permission. The pressure dropped to 68. She paged Dr. Whitfield simultaneously, the standard protocol: call the attending, notify the resident, wait for the team to arrive before proceeding with anything beyond basic life support. The phone system showed the page went through at 1:53 a.m. Standard response time was for minutes from the surgical floor. Morrison had maybe 2. The paging system crackled almost immediately, but it wasn't footsteps. It was Whitfield's voice, pulled from somewhere: his office, his car, his apartment, sharp and precise and carrying that particular tone of a man protecting his jurisdiction. "Do not open that chest." His voice came through the nurse station speaker, loud enough for 3 other nurses to hear. "Do not crack Morrison's sternum without surgeon approval. That is a direct order, Margaret. Wait for the surgical team." The pressure hit 65. Margaret had worked for 43 years. She had worked in field hospitals where there were no surgeons, no operating rooms, no committees to consult. She had worked in places where the choice was perform the procedure with her hand shaking or watch someone die while she waited for approval from someone who wasn't there. The muscle memory of those decisions lived in her fingertips. But she was a nurse at Seattle General now. She was someone with a suspicious gap in her personnel file, someone Dr. Whitfield had already marked for removal, someone who couldn't afford one more incident that looked like insubordination. She stood at the crash cart, one hand on the thoracotomy tray. The metal was cold. The instruments inside were arranged with military precision: scalpel, Mayo scissors, chest retractor, hemostats, all waiting for hands that knew exactly what they were doing. "He'll be dead in 90 seconds, Margaret said to the empty room. Not to Whitfield. To the facts. To the physics of a body in arrest. Whitfield's voice came back immediately, and there was something in it now, not concern. Something colder. Something that sounded like leverage. "If you proceed without authorization, if you crack that chest without a surgeon present, you're finished here. I will personally ensure you never work in a nursing role again. Not here. Not in Philadelphia. Not anywhere I have a phone and a contact list. Do you understand me?" The central line flatlined. The monitor showed no pressure, no waveform, just the digital straight line of a heart that had stopped working. The sound it made was almost musical, a high-pitched beat that came once, then nothing. Morrison's chest had stopped moving. His skin had gone the color of concrete. The challenge coin in Margaret's pocket felt suddenly warm, pressed against her sternum like something alive and aware of what was about to happen. She had 10 seconds, maybe 12, before irreversible brain damage became the only outcome. 61 years old, and every decision she'd made that mattered had come down to this exact moment, the choice between survival and rules, between the life in front of her and the license in her wallet. She thought about the last email Danny had sent, the one she'd read in the hospital cafeteria so many times the words had worn into her memory like a river-wearing stone. *Mom, he's the kind of officer you were. The kind who doesn't leave people behind. *. Margaret's hands didn't shake when she reached for the scalpel. She'd prepped the site the moment the alarm first sounded, cleaned Morrison's left chest wall with betadine, the orange stain spreading across his skin like a map of where the blade would go. She found the landmarks by feel, the second rib and third rib by palpation, the intercostal space between them as familiar to her hands as her own heartbeat. She'd done this in Helmand Province with nothing but a field dressing kit and a flashlight clenched between someone's teeth. She'd done this in a convoy truck while rounds pinged off the metal hull. She'd done this with artillery fire close enough to feel the percussion in her chest. She could certainly do this in an air-conditioned hospital at 1:54 in the morning. The scalpel slid through skin like it was cutting butter. 4 inches. Left anterolateral thoracotomy, the incision angling from the sternum down toward the axilla, her fingers knowing the depth before her eyes registered it. Blood welled up immediately. Morrison's cardiopulmonary system had shut down, but his arterial pressure was still there somewhere, still fighting to maintain perfusion even as his heart refused to work. The bleeding meant he wasn't dead yet. The bleeding meant there was still time. She reached for the Mayo scissors, didn't wait for them to be handed to her. Expanded the incision through the pectoralis major, felt the individual muscle fibers separate under the pressure, kept her movement smooth and economical because hesitation meant she'd start second-guessing and second-guessing meant Morrison died and she would spend the rest of her life wondering if the scalpel tremor cost him 40 years. The intercostal muscles came next, the scissors cutting between the ribs with a sound like fabric tearing, and then there was the pleural membrane, the thin translucent envelope around the lungs, and when she cut through it the sound changed, a soft hiss of air escaping, the sound of a body's protective seal being opened. Morrison's left lung collapsed. The chest retractor went in next, the metal spreader forcing the ribs apart to create a window into the pericardial space, and what she saw there made every decision crystallize into absolute clarity. Blood. Not just fluid. Blood. Pooling around his heart like it was drowning in its own vessel, compressing the left ventricle, preventing the muscle from expanding, making each attempted contraction pointless. Tamponade. The shrapnel fragments must have torn a small coronary artery on the way out. The bleeding had been slow, barely visible, accumulated over hours. She reached in. Her hand fit inside his chest cavity like she'd done this 10,000 times, which she had, just not in this particular hospital. Her fingers found the pericardium, the fluid-filled sac surrounding the heart, and she made the incision there with surgical precision, released the trapped blood, felt the pressure decrease under her palm like a valve opening. The heart itself was beneath her fingers now, cold and still, the texture of a stopped muscle, the color of meat that had been without oxygen for too long. Her hands moved. Direct cardiac massage. They called it the Zahorsky maneuver in the academic literature, but in the field hospitals, in the combat zones, in the places where you couldn't wait for a surgical team that was never coming, they called it staying alive. She positioned her thumb and fingers around Morrison's ventricles, felt for the landmarks she'd memorized from 1,000 anatomy lectures and 100 actual procedures, and began the compression. Not violent. Controlled. Gentle pressure, release, gentle pressure, release, the motion of a hand that understood that a stopped heart didn't need force. It needed the right pressure in the right place from someone who understood that the muscle fiber ran perpendicular to the direction of compression, that you worked with the architecture of the organ, not against it. The monitor stayed flat. 3 compressions. 4. 5. The room felt very small. Margaret was aware of other nurses arriving now, the sound of running feet, someone saying she's cracking the chest, is this authorized, and another voice saying call cardiothoracic, tell them code blue, stat, and underneath all of it the sound of her own breathing, controlled and measured, the way you breathed when you were underwater and couldn't afford to panic. 8 compressions. 9. And then something changed. A subtle shift in the muscle beneath her fingers, a tightening, the sensation of fibrillation converting back to organized rhythm. Her thumb felt the first contraction happen, weak, almost imperceptible, but present. A heartbeat. 1. 2. The monitor showed it half a second later, a single blip on the flat line, then another, then a stutter of sinus rhythm, erratic but alive. The pressure reading jumped. 60. 70. The color started returning to Morrison's lips, the duskiness fading toward something that looked almost human. 95. 105. Normal. The chest retractor was still spreading his ribs apart, his open chest cavity still exposed, and Margaret was aware now of additional people in the room, the surgical resident, the trauma attending, someone she didn't recognize in scrubs, and finally, 6 minutes after the first alarm, Dr. Whitfield appeared in the doorway. His eyes moved from Morrison's open chest to her hands covered in blood to the monitor showing sinus rhythm and stayed on her face long enough for her to understand something shift in the air between them. Not respect. That would come later, if it came at all. What she saw in his expression was closer to the look a man gets when he's realized he's miscalculated the depth of water before diving. The surgical resident stepped forward immediately, began assessing the field, started calling out orders to close and move Morrison to the operating room for formal repair. Margaret stepped back, her hand still dripping, her scrub soaked with blood up to the elbows. She didn't speak. There was nothing to say. The work was done. The patient was alive. Everything else was just noise. Whitfield didn't move from the doorway. His jaw was tight. His hands were clenched at his sides. He was looking at the thoracotomy tray, at the instruments arranged precisely as they had been when Margaret took them, and then back at her face, and in that moment Margaret understood that she had just made a decision that couldn't be undone. She had just drawn a line between the woman she was pretending to be and the woman she actually was, and there was nowhere in the middle anymore. She walked to the sink without being dismissed, washed her hands under scalding water, watched Morrison's blood spiral down the drain like it was being erased, and felt the weight of the challenge coin in her pocket settle lower, heavier, waiting. By 8:15 a.m. on a Tuesday morning that felt like it belonged to someone else's life, Margaret Walsh was no longer a nurse at Seattle General. The paperwork said immediate administrative leave pending investigation, but the words underneath were written in a language she understood perfectly: "You're finished here." The hospital attorney, a woman named Patricia Chen with steel-gray hair and the kind of smile that appeared in depositions, sat across from her in a windowless room on the 5th floor, asking questions about Margaret's employment history before 2012, taking notes when Margaret said there were no records, no references, no digital footprint before that year. The attorney's pen clicked methodically, click click click, like a countdown to something neither of them could stop. "That's unusual," Chen said, not looking up. "Most nurses have verifiable work history going back 15, 20 years. Where were you?" Margaret's jaw tightened imperceptibly. "Classified." The word hung in the room like smoke. Chen's pen stopped. She looked up slowly, studied Margaret's face for 3 full seconds, then returned to her notes. "I'll need you to sign this acknowledgement of suspension. Effective immediately. You are not to return to any unit. Security has been informed." Margaret signed the document without reading it. Her hand was perfectly steady. She had signed orders before that meant different things: orders to extract 3 targets from a collapsed compound, orders to stay quiet for a decade, orders that came from people who could make citizens disappear. A suspension notice was just paper. But the way it landed on the table between them felt heavier than that. By 8:36 a.m., before Margaret had even reached her locker on the 3rd floor, Dr. Whitfield made the first of his calls. The hospital president, Richard Bancroft, was still in his office reviewing a surgical budget when his private line rang. Whitfield's voice came through measured and grave, the tone of a physician with grave concerns. "Richard, we have a crisis. One of our nurses performed an authorized open-chest cardiac massage on a patient last night without a physician's direct order. Reckless cowboy medicine. She bypassed protocol, endangered patient safety, and when I arrived she'd already compromised the sterile field. I'm concerned about our liability exposure if this escalates." Bancroft had heard this tone before from senior staff. Competent people protecting institutional interests. "What's her name?" "Margaret Walsh. Cardiac ICU. 11 years employed, but I've been documenting concerning autonomy issues for months. Insubordination. Refusing to follow the chain of command." By 9:14 a.m., Whitfield was on the phone with Jennifer Marks at the Pennsylvania State Nursing Board. His voice different now, concerned colleague to regulatory authority: "I need to report a procedure violation. Margaret Walsh, RN, Seattle General in Philadelphia, performed an unauthorized emergency thoracotomy at 1:52 a.m. without physician authorization. But the concerning part is her employment history. She has no documentation before 2012. No verification of previous work experience, no references, no educational records going back more than 11 years. I'm wondering if her credentials are even legitimate." Marks wrote it down. "Do you suspect fraud?" "I suspect something," Whitfield said carefully. "And I think it needs investigation before she harms another patient." By 10:33 a.m., Whitfield had composed an email to 3 board members, each with different institutional leverage. To Clarence Donnelly, the hospital's legal counsel, liability exposure from an increasingly erratic employee with an undocumented past. To Father Martinez in pastoral care, who had influence with the Catholic Archdiocese that held the hospital's charter, behavior that suggests mental instability and concerning autonomy issues. To Susan Park, the chief financial officer, personnel file problems that could expose the hospital to regulatory penalties. He didn't write about Morrison being alive. He didn't mention the precision of Margaret's intercostal incision or the fact that the patient's heart responded to direct massage performed by hands that had done this before, in places where hesitation meant death. Whitfield wrote about process violations and documentation gaps, about liability and institutional risk. He wrote about a problem that needed removing. By 2:51 p.m., Margaret sat in her car on the third sublevel of the parking garage. The car was a 2008 Honda Civic, grey, nondescript, paid for with cash from a credit card that didn't exist before 2012. She had driven this same car to work for 6 years, had parked in this same spot 1,700 times, had never once thought about what she would do if she couldn't come back. The steering wheel was cold under her forehead. The parking garage smelled like exhaust and wet concrete, and somewhere 3 levels up, people were ordering lunch from the cafeteria, discussing weekend plans, living in a world that had stopped including her 2 hours ago. She couldn't turn the key because the moment she did, she would have to go somewhere. Back to the apartment with the blank walls and the photograph she'd never unpacked. The challenge coin in her pocket felt like it weighed 5 pounds. She had run her thumb across it in supply closets and bathroom stalls for 11 years, a worn talisman with a faded combat diver insignia on one side and a date on the other, 2009. The coin had been in her son's pocket when he died, and she had no right to it, but she carried it anyway, the same way she carried the guilt of being alive when Danny wasn't, of having a new name and a new social security number and a new life while his remained exactly the same, 23 years old, Helmand Province, under Captain James Morrison's command. The one person she'd saved last night. The one person she couldn't save 3 years ago. The silence in the parking garage was almost perfect, broken only by the distant sound of a car alarm 2 levels up and the metallic ping of the cooling engine beneath the hood. Margaret's hands rested on the steering wheel, steady and scarred, the kind of hands that had held lives together in field hospitals and sterile operating rooms alike. Those hands had impressed no one until they became dangerous. The moment they stopped following protocol, the moment they acted on instinct and training instead of permission, everything had shifted. Whitfield had seen it. He had watched her work and recognized that she wasn't deferring to hierarchy the way the system demanded. She was operating from something older and harder, a code that predated hospital policy, that transcended the chain of command. It was the code that had gotten her buried in the first place. Her phone buzzed at 3:02 p.m. A text from an unknown number, call when safe. Chen was the security guard who had escorted her out, the former Marine from Ramadi who had seen the red and gold challenge coin clipped to her ID badge when she'd collected her things from the locker. He hadn't said anything out loud, but his eyes had gone somewhere distant, the way men's eyes did when they recognized someone they thought was dead. Margaret didn't call. She sat in the car for another 37 minutes, forehead pressed against the steering wheel, unable to move, unable to think past the fact that for the first time in 11 years, she had no job, no cover story, no legitimate reason to exist in Philadelphia. The suspension notice was in her bag. The hospital had her social security number, her employment history going back a decade, her fingerprints on file from the initial hire. If Whitfield started asking the right questions, if he connected dots that shouldn't connect, if he made calls to people who still had her photograph and a bounty in 3 countries, everything she had built would collapse like a building with its foundation removed. She had been ordered to forget who she was. She had been given a new name, a new social security number, a new life, with one condition: never surface. Never acknowledge what you were. Never let them know you're still alive. The Navy had called it protective custody. Margaret had called it existence. And now, sitting in a car on the 3rd sublevel of a parking garage beneath a hospital where she'd worked longer than she'd done anything else, she understood that the line between hiding and burying yourself was not a line at all. It was an illusion. You couldn't be one thing in the world and something else in private. You couldn't save a man's life using skills you were supposed to forget and expect no one to notice. You couldn't refuse to defer to a hierarchy built on appearance and expectation and assume that the hierarchy would simply let you be. Whitfield wouldn't let her be. He was making calls now, pulling threads, asking questions that would get answers if anyone knew where to look. And someone would look, because in the institutional world Margaret was trapped in, people like Whitfield had the power to make that happen. The parking garage remained empty except for Margaret's car and 3 others parked far away, their owners still inside the hospital, still part of the world that had just expelled her from it. She sat in the darkness between fluorescent lights, her hand steady on the wheel, her jaw tight, her breathing controlled. Pain was information. She had learned that in a field hospital in Kandahar, and the information her pain was giving her now was clear: everything she'd built in 11 years of invisibility could be unmade in 48 hours. And that wasn't even the worst part. 48 hours after the suspension notice, the medevac alert screamed through Seattle General at 2:36 a.m. Incoming, Afghan civilian contractor, sepsis, fever spiking to 104.8 degrees, airway compromised, ETA for minutes. Margaret wasn't supposed to be there. Her badge had been deactivated. Her shift was cancelled. But she'd spent the last 2 days in her apartment staring at the tarnished challenge coin, running her thumb over its worn surface in the dark, and when the siren started, muscle memory pulled her toward the hospital like a magnet pulls iron. She stood in the hallway outside the ER in civilian clothes, watching through the observation window as the stretcher rolled in. The man on it was delirious, his lips cracked, his eyes rolling back as fever twisted his mind into a place between languages. The respiratory therapist was fumbling with the intubation tray. The resident ordered propofol and succinylcholine, standard dosing, standard protocol, and that's when the Afghan man grabbed the stretcher rail with shocking strength and began screaming in Pashto, over and over, his voice ragged and desperate, calling out a name that hadn't been spoken aloud in 14 years. Shaitan Banafsha. Shaitan Banafsha. Purple Devil. Purple Devil. The room went dead silent. A nurse froze mid-step. The resident looked up, confused. The security guard standing near the entrance, a man named Garrett who'd served in Ramadi, felt the color drain from his face. He'd been 14 miles from FOB Fallujah when the intelligence came through about the Navy corpsman with the call sign Purple Devil, the one who'd walked into a compound that was supposed to be empty and extracted 3 high-value targets out of a collapsed basement in complete darkness, using nothing but a field radio and a conviction that abandoning people was not something she did. Garrett's eyes moved toward the observation window where Margaret stood, and something in her stillness, her absolute unflinching focus on the patient, made him understand. The way her hands had clenched into fists. The way her breath had frozen. The way she was no longer standing like a nurse, she was standing like a person who'd just heard her war call her name across 14 years. Garrett walked to the doorway. His voice came out low and steady, the way it had on operations when clarity mattered more than volume. That's not a nurse. That's Master Chief Petty Officer Walsh. He said it as a statement, not a question. One sentence. 14 years of classified service, 2 Purple Hearts, a Silver Star, and an operation that officially never happened, all compressed into a single declarative statement that made the resident stop mid-push of propofol and stare at the woman in civilian clothes like she'd just materialized from a ghost story. The Afghan man began seizing. His oxygen saturation plummeted to 62%. The monitor screamed in short, percussive beeps like gunfire. Margaret moved without permission, without hesitation, her hands already gloved because she'd never actually stopped being ready. She positioned the endotracheal tube with the precision of muscle memory, secured it with tape that didn't tremble, ordered 100 milligrams of succinylcholine to paralyze him, ordered the vent to 16 breaths per minute, ordered for liters of normal saline wide open. Her voice had dropped an octave. It wasn't a request. It was a command. Within 90 seconds, the man's oxygen sat climbed to 94%. His heart rate steadied. His seizure stopped. The room began breathing again. The hospital administrator had already called emergency. Within 20 minutes, a 2-star general named Hawthorne arrived with a classified jacket and an expression that suggested he'd seen worse but not much. He took one look at Margaret standing over the patient, covered in the man's blood now, her jaw set like someone who'd made peace with violence a long time ago, and asked where her CO was. When someone said she was on suspension pending investigation, Hawthorne's eyes went flat. He didn't speak to Margaret. He walked directly to the conference room where the hospital board was assembled, where Dr. Whitfield sat explaining to 3 board members how Margaret's undocumented history posed an unacceptable liability. Hawthorne placed a classified file on the table. It made a sound like a gunshot against mahogany. He opened it without permission from anyone. He began reading aloud, his voice precise and devastating, the kind of voice that had commanded soldiers in places most people didn't know existed. Master Chief Petty Officer Margaret Walsh. Service record beginning 2001. Afghanistan, 2008 through 2012. Bronze Star with Valor, 2009. Second Bronze Star with Valor, 2010. Silver Star, 2011, classified operation, Helm and Province, 17 lives, all hostile extraction, 0 civilian casualties. He turned a page. The paper made a soft, deliberate sound. Medically reassigned 2012, discharged with distinction, identity classified, social security number changed, all records sealed by executive order. She's not undocumented, Dr. Whitfield. She's invisible because that's what we asked her to be. Whitfield's face had gone from red to grey. His mouth opened and closed like a fish in a tank, searching for water. He tried to speak. This is highly irregular, you can't just. General Hawthorne cut him off with a gesture so small it was almost gentle. 2 military police officers who'd come up in the Black Hawk with a general moved to flank Whitfield's chair. Not threatening. Just present. Just clear about who was actually in charge of the room. Captain Morrison was conscious now, his 4 lines running clear, his catheter removed, the septic shock broken. He asked to see Margaret. When she appeared in his doorway, still in her blood-stained civilian clothes, still with that face like carved stone, he began to speak. His voice was steady but threaded through with something that sounded like grief. I knew your son. Lance Corporal Danny Walsh. 3rd Battalion. He died on a patrol outside Sanjin in 2021 under my command. I carried his challenge coin every day after that. I have it still. I've worn the matching one you sent with him for 3 years. Morrison's eyes held hers. You just saved the life of the man who couldn't save your sons. I understand if you can't forgive that. Margaret didn't respond. She didn't need to. The silence in the room was so thick you could hear the ventilator wheeze its mechanical rhythm like a living thing. She reached out and placed her hand on Morrison's shoulder, and that gesture, that single, deliberate touch, said everything the military had trained her never to say out loud. The hospital president, a man named Kowalski who 10 minutes ago had been nodding along to Whitfield's termination recommendation, suddenly discovered urgent interest in the personnel file in front of him. Master Chief Walsh, he said carefully, would you consider staying on as head of emergency medicine? We could discuss restructuring, obviously. Significant salary increase. Whatever you need. His voice was the voice of a man who'd just realized he'd been about to fire a decorated combat veteran for the crime of saving a life without asking permission from someone who'd never qualified to save anything. Whitfield's phone buzzed. Then again. Then twice more in rapid succession. Texts from the 3 board members he'd called that morning, all suddenly unreachable. One auto-reply explaining that said board member was on sabbatical, do not contact. Whitfield's hand reached for his phone and then stopped, because General Hawthorne was already dialing, and the call went to the State Medical Board's director, and Hawthorne's voice explained, in a tone that made clear this was not a question, that a physician named Whitfield had attempted to terminate a decorated veteran for saving a life without waiting for administrative approval, and asked if there were procedures for reviewing a physician's fitness to practice when ego had become a liability to patient care. The silence that followed was absolute. Whitfield's face had gone the color of old bone. I want an attorney, he said, his voice small and thin as tissue paper. You're not under arrest, Hawthorne replied. You're just unemployed. As of right now. Effective immediately. You'll surrender your credentials in front of the staff you poisoned against a decorated war hero. Consider it a teaching moment. The public destruction came at 4 p.m. in the main atrium of Seattle General. The entire hospital staff was assembled, doctors, nurses, administrators, respiratory therapists, janitors, everyone whose work kept the place running. Local news cameras rolled. A PA had smelled the story and called 3 networks. Hawthorne stood at a podium with a microphone, and he repeated Margaret's service record in a voice that made it impossible to look away. Silver Star. Bronze Stars with Valor. The 2009 operation that officially never happened. 17 lives extracted. 0 civilian casualties. The principles of service, sacrifice, and patient care embodied in a single person who'd walked into a career in nursing not because she was broken, but because she understood that heroism didn't require a uniform, it just required hands steady enough to hold life together. Whitfield was required to stand on the platform beside Margaret, required to face the staff he'd led through years of intimidation and contempt, while Hawthorne described each act of valor, each life saved, each time Margaret embodied the oath Whitfield had pretended to serve. When the general finished, he turned to Whitfield with a smile that wasn't kind. "You have 5 minutes to clean out your office. Security will escort you." 30 staff members pulled out phones to film. Whitfield walked through the atrium in complete silence, 200 people watching, no one speaking, his footsteps echoing on tile like a countdown. When he reached the exit, a nurse he'd once called Sweetie held the door open and said, without inflection, "Community health clinic work might suit you." 6 months later, Margaret stood in dress blues at the dedication ceremony for the Morrison-Walsh Combat Medicine Wing at Seattle General. Her uniform was the same one from 2012, kept in a garment bag in her closet, the ribbons and medals now legal to wear. Captain Morrison stood beside her in his own dress uniform, his hand on her shoulder, both of them facing a wall-mounted photograph of Lance Corporal Danny Walsh in Marine Corps blues, 22 years old, frozen in time, his challenge coin displayed in a glass case beneath the image. Morrison gave the dedication speech. He described how Danny talked about his mom who served, how Danny carried her challenge coin until the day he died, how Margaret saved the life of the man who wrote her the letter no parent should receive. A Navy chaplain presented Margaret with the Navy Cross that had been classified for 14 years, pinned it on her uniform while flashbulbs popped like distant artillery. Afterward, Margaret learned that Whitfield was teaching CPR classes at a community college on the other side of Philadelphia for $18 an hour. That none of the hospitals in a 200-mile radius would return his calls. That the video of his public firing had gone viral with 4 million views. She didn't smile at this information. She just nodded once, acknowledging that the world eventually balanced itself. She found Captain Morrison in the new wing's meditation room, sat beside him in silence, both of them holding matching challenge coins. "Danny would be proud," Morrison said. Margaret's composure finally cracked, just slightly, her jaw tightening, her eyes wet. "He always said true class is what you do when the lights go out. I spent 3 years in the dark, thinking I'd lost the right to be proud of what we did. Thank you for turning the lights back on." Morrison squeezed her shoulder. Outside, 150 Special Forces soldiers in dress uniforms stood in formation, holding salutes, waiting for their Master Chief to come back out. If you've ever been underestimated by someone who had no idea who they were standing next to, like this video. Subscribe for more stories about the quiet heroes who carry the weight of secrets and service. Comment below, was Whitfield's punishment enough, or did he deserve worse? And share this with someone who needs to know that true strength is often invisible until the moment it saves a life.